I'm a Navy urologist, and I'm a urologist that has subspecialty training in oncology. So I'm a urologic oncologist. My practice primarily has been within the military as a Navy doctor, a Navy urologist in various settings, both in hospitals, deployed settings, and in very well-resourced centers within the DoD, and also in austere environments overseas for other reasons. But I also have my experience in my residency training and in my fellowship training in the civilian practice, and did my urologic oncology fellowship training at Sloan Kettering in New York City, and my residency training at Eastern Virginia Medical School in Norfolk, Virginia. And so now I'm primarily practicing at Walter Reed. I work at the Center for Prostate Disease Research, which is affiliated with the military's medical school, Uniformed Services University, and it's part of the Murtha Cancer Center, which is the only military comprehensive cancer center in the world. A lot of patients call me Dr. Chesnut. Within the military, Commander Chesnut, I'm comfortable with either, as long as I'm appealing to what the patient needs at the time. Some patients are very within the military or are very rank and structure oriented, and they get a lot of confidence in knowing that their physician has some understanding of their background and training, and being a commander is meaningful in that regard. And other patients just want someone that can be a good doctor that they understand, and so I go either way. In the military, we're trained with rank and structure, and different ranks have different authorities. The way I describe it is within the examination room and within the hospital, the doctor and patient relationship is sort of a rank-free zone. And so my goal as a urologist is to take care of the patient, whether they have 4 stars on their shoulder or none, and to make them feel comfortable. Now, sometimes patients with higher ranks have different varying schedules, and there's a lot of behind the scenes things to make sure that we can take care of their specific needs when they may be flying in or out of the country at a moment's notice. But you know what? We have the same issues no matter what rank it is. And at the end of the day, we have somebody with concern for a prostate cancer diagnosis or a prostate cancer diagnosis, and they have needs that are human needs, and rank-based needs usually go out the window pretty quickly, because it's me and the patient and their family and our comprehensive team. We have nurse practitioners, social workers, sexual medicine experts, radiation therapy experts. Everybody sort of comes together to focus on what do you need and what's your issue and how can we help, because prostate cancer is different. You know, there are different stages and grades and treatment recommendations, and it's almost like a snowflake. There may be no right or wrong answer for everybody, but there is a right or wrong answer for each patient. And sometimes the rank of the patient plays into what their needs are at the time, and sometimes not. We try to be very cognizant of that. It's a big area of anxiety for patients and their families when they come in with a new prostate cancer diagnosis, because they may have talked to Uncle Frank or their neighbor down the street or a cousin that has prostate cancer who says, this is what I had, this is the best thing for you, or this is what I had, don't do this. And oftentimes the idea that there are differences in patient preferences, patient treatment goals, and outcomes, and what is tolerable as a side effect and as a treatment course for one patient may or may not be tolerable or desired in another patient. So all these things come together to the point where there's a little bit of a back and forth, and it's sort of a patient-centered, physician-guided, and team-based approach to saying these are the different options, and these are the different implications of these treatment choices on you now, on treatment choices in 3 months, 3 years, or 30 years down the line. And sometimes, particularly for military men, but I think also for all patients, you would almost want someone to say, this is your disease, this is what you do, and take your emotions and thought and ideas out of it, because now that you have inputs and choices and there's no single right answer, there's a little bit of fear that you're making the wrong decision or you're not emphasizing what you want appropriately. So I always tell patients to come in with an open mind and to think in advance of what sort of ideal treatment endpoints and start points and intermediate points you have, because those are important to talk about, because something that's very important for one man may not be important for another. But by the same token, what's important to you needs to be able to be discussed freely with your team, because the last thing we want is to embark on a treatment course that cures the cancer, but cures the cancer in a way that's not acceptable for you, because there are multiple ways to treat this cancer. We have to mention is there is no true protocol. There's no I'm not going to defer to you on certain things that I think are important, and you're not going to defer to the sexual medicine person who has different comments, and everyone sort of comes in on even footing. And I think defer is probably not the right word, but we're not going to overemphasize one thing without sort of getting a full breadth of the understanding of the disease. Military men and their families are really are so almost team geared, and once you're given permission to be part of the team and an active player in your decision making and treatments, it's very helpful. Sometimes people have to be invited to do that, because one of the things I've seen, I think it is more common in civilian patients and all patients, where you come in and there's a deference to what the doctor says, or a deference to what certain family members may say. And unless you invite the patient to say, this is our decision together, and I'm not going to go to sleep until you're comfortable, and I hope nobody else will do the same. We're all in this until the end. And here at the Center for Prostate Disease Research, we have a higher percentage of African-American patients than in a lot of the larger cohorts where you see some of the studies from. And so what we have found is I agree, we are diagnosing prostate cancer at younger age among our African-American patients, and oftentimes at higher stage. But what we find is among an equal access to screening, treatment, follow-up, and all care where cost doesn't come into play, that the differences in survival and outcomes do start to level off. And so I do believe that there is some significant barriers to care that are responsible for this. But there are also some genomic, and proteomic differences between prostate cancers in African Americans and in Caucasian Americans that we are seeing, and we're studying that very actively at our center. And I think that can help target and personalize the treatments for different patients from different backgrounds based on their disease. But the bottom line is, when we have everybody coming to the doctor regularly, and your health is our entire enterprise's best interest, we're finding that those disparities are very much improved. I think within the military, we don't have any sort of unique disparities, but we do have unique exposures. And so I think one of the things that we are very actively looking into in prostate cancer and in other cancers are what sort of military-induced exposures are related to cancers. A lot of people have heard about the Agent Orange exposures and the risk for bladder cancer or kidney cancer. We haven't seen that in prostate cancer, but that doesn't mean we're not looking. But there are things that we're seeing in some of the younger patients now with burn pit exposures. We're not seeing any increased rates of prostate cancer among those patients, but that's not because we're not looking. We are looking, and that's something that with time will mature. And so one of the things that we do have the benefit of is we can look through the medical record and we can know where someone was deployed and when, and we can help determine if there's any associations, and ultimately if that matters for treatment or prognosis. Right now, we don't have that. I was in Djibouti, and I've been to the Middle East several times, and then also within the medical role down on humanitarian missions, other parts of the world, particularly in Central and Southern America. Everybody can recall the smell. It's something that you'll remember. It's a heavy smell, and there can be a fog, and it almost darkens the environment, and a haziness. It's hard to say which is due to the burn pit and which is due to the heat and which is due to the sand and the things. There's a whole bunch of things swirling around. But the fact is, the burn pits were a part of life for much of the conflict in the Middle East. And the things that were burned, we're still learning what sort of impacts that has. And it would be not right to assume there's no impact. It would be probably wrong to overestimate the impact at the same time. But like scientists, we want to look into it specifically and see what are there any metabolites in the prostate that we can determine are related, or in the bladder or other places? And the only way to get there is through science and through effort and recognizing that this is an unknown and not tolerating it an unknown, but looking into it. There is a lot of anxiety and uncertainty to what role these things play in disease states. And sometimes it's very unsatisfactory when a patient will come to me or their family will come to me and say, is this related? And I have to look them in the eye and say, I really don't know, but we're going to look into it. And so I think the important thing to do in situations like this is to sort of, for patients and family members, to sort of know their military and deployment history and where they were, and exposure history, and keep note of that. And I have patients all the time, they bring those with them to appointments, and we record it in the medical record. So when it comes time, so should there ever be a diagnosis that may ultimately be attributable to this, we can look back in the medical record, which is part of the military record, and see what associations we have. For a long time in the military, there was no acknowledgement of gay partnerships or marriage, and that's not the case anymore at all by any stretch of the imagination. And we do have patients, actually homosexual patients, and we also have had some transgendered patients post-surgery who have had prostate cancer. And the approaching of treatment of patients who have either in the military or in life have had a lot of times some, I'm not sure what the right term, traumatic or even discouraged conversations with medical providers due to distrust because of not acknowledging sexual orientation is very important to recognize. And I think just discussing it with a patient and their partner is very important. And so I don't want any patient of any sexual orientation to feel that they're alone. But I would have to agree with the statement. I do feel that many gay patients do feel a little bit more alone than simply due to their experiences within the medical treatment facilities in the past.
Yeah.
For prostate cancer, there's an element of equivalence of treatments in different disease stages. And so for localized prostate cancer, many men have the opportunity for active surveillance. Others have opportunities for localized surgery with prostatectomy or with radiotherapy. And there are several different radiotherapy options with ranging from brachytherapy to high dose rate brachytherapy to different fractionations of radiation over different periods of time, sometimes with hormonal treatment, sometimes without. And each of those come with a little bit different treatment related side effects and sort of ways of monitoring disease response based on PSA levels after treatment. And so I encourage men to think about what's important to them with their recovery, and to realize that in order to feel confident with your decision 5, 10, or 15 years from now, the studies have shown the best predictor of that is feeling involved and empowered to say, no, this is what I want, this is what I feel comfortable with, and not being sort of a passive sort of receiver of treatment that may be someone else's desire but not yours. I want them to sort of think objectively about how is their urinary function now? What would be a tolerable improvement or impact of that in a negative way? Same for erectile function. Other things are just thinking about overall health status and other diseases and treatments and other things that are competing with prostate cancer for impacting your life in a negative way, because treating prostate cancer is my job, but at the same point, the patient may also have other issues with heart problems or diabetes problems or other things that impact their prostate cancer treatment decisions and their long-term goals. So thinking about those are important. And the best thing to do for a patient is to be in the best, we all wish this, but to be in the best shape possible when you have something like this, so you can tolerate any sort of treatment that we would recommend. I was a urologist at Camp Lejeune, North Carolina, and I was the only urologist there. So if someone in there had prostate cancer or any other urologic treatment issue, I was the only choice. But that's that varies depending on location. Whereas here at Walter Reed in Houston, there are many of us. Similarly, people have that problem if you're in a small town in Middle America where you have choice issues. Now, one of the things we do have is an example is there's someone that had an active duty person who has prostate cancer who's currently stationed in Italy, and their team reached out, and we're bringing that patient through the military back for treatment here with us in Bethesda because we have sort of the team and the outfit to do everything a lot easier than a smaller one urologist place that doesn't do quite as many of those. And so I would encourage patients that are in places like that to ask questions is there someone else that can come here, or can I go somewhere else? And because those options are there if you know to ask for it. There are some wonderful things about the military, and it's the camaraderie of the patients, the providers, the hospital. We really are one team, and there's nothing better than going into an exam room or an operating room, and everybody there has had shared experiences of deploying or of some going into harm's way, others staying in large hospitals for longer periods of time. But everybody has that same experience of service to their country and service to their teammates and peers. And I think when I walk into an exam room and I see someone who has given so much for me to be able to have a career where I'm doing exactly what I love, urology, urologic surgery on cancer surgery on prostates, and managing prostate cancer. It's an opportunity for me to do what I love with the people I love in a system that no system is perfect, but this one it really is equal access. And if someone has a need, I don't have to go ask somebody if I can have permission to give this medicine or that one if it's not in network. And I don't have any worry about my overhead or costs or overruns. My worry is the person right in front of me and their family and their goals. And if I can't do it, I can find someone that can, or to meet whatever needs they have. It's been very rewarding when I see a patient, whether they are, and I'll just give a couple recent examples, whether they are a very senior officer with 4 stars on their shoulder, or whether they're someone that it just wants to get their treatment so they can go back overseas and kick down doors and do what they love. The ability to do that, and then to get that postcard back from overseas saying, here I am, look what I'm doing now, when 6 months ago I was a patient of yours, and now they're overseas doing what they feel is their mission and haven't dropped a beat. So it's really a special place to work for these patients in this hospital system. I would do it again tomorrow.